Now, I'd like to introduce Dr. Stephen Kopetsky to start this off. Steve's been a member of our cardiovascular division for decades and decades, but he is one of our star clinicians nationally and internationally recognized in the field of preventive cardiology. And Steve's the one that I always call for any questions or refer patients to for some of these. We've got a lot of new things going on in preventive cardiology, and Steve's the one that we always turn to for the right answers on these. So he's going to be giving an overview on kind of prevention in coronary artery disease, but let's first start with the questions here. So we've got a 48-year-old woman. History of paroxysmal atrial fibrillation, no history of elevated LDL. Her medications are amiodarone, estrogen, diltiazem, warfarin, hydrochlorothiazide. She's euthyroid. Her total cholesterol is 242. LDL is 192. And the prior LDL last year was 114. The most likely cause of the high LDL, because all these medications were added, are amiodarone, estrogen, diltiazem, warfarin, or hydrochlorothiazide. Good drug-drug interaction, drug effect question that's of practical relevance. Let's see what you would say for that. Ooh. Let's take a look, Steve. Okay, next question. You're seeing her in late February. She brings a CT scan for coronary calcium, and her score is 1,263. She's got no risk factors other than age. Her ECG is normal. She has no symptoms, no history of myocardial infarction. She's physically active. Which of the following is true? There's no easy way to add CT results into her risk score. The statins have not been shown to be helpful in this group. She should have a stress test. If her score was 0, her risk would be less than 1 in 1,000. Physical activity has no effect on statin benefits. So which of the following is true? There's one right answer here. Go ahead and pick your answer. And the answers are here. Okay. Got that, Steve? All right, next one. Which nutritional patterns has been shown to lower CV morbidity and mortality? Dietary approach to stop hypertension, the DASH diet that Amy talked about yesterday, the Mediterranean diet, the DASH and the AHA low-fat diet, the Mediterranean paleo diet, the DASH and Mediterranean diet. So you want to be able to lower CV morbidity and mortality by diet. All right, final one. 63-year-old man for primary prevention. Hypertension, father had myocardial infarction at age 64. Pooled cohort risk is 14%, and you'll hear about that. The LDL is 126. The meds are amlodipine, hydrochlorothiazide, and metformin. Which of the medications is contraindicated in this patient? Rosuvastatin, atorvastatin, simvastatin, fluvastatin, or pitavastatin? At those dosages. Okay, Steve, come on up. Great. And the majority said simvastatin. Okay, Dr. Kopetsky, take over.
Thank you, Dr. Shimura. Good morning. Here are my disclosures, and I'll speak only on proven evidence and in the guidelines. So the 4 learning objectives this morning over the next few minutes will be first to identify cardiovascular risk factors in patients without known coronary artery disease and use them to predict their risk for cardiovascular events. To second, select appropriate non-invasive testing to further risk stratify patients without known CAD. Third will be to apply management strategies to the prevention of coronary artery disease, including therapies to reduce risk factors and appropriate counseling regarding lifestyle. And then last, learn to initiate appropriate lipid-lowering therapies to reduce the risk of future events, recognizing potential side effects and drug-drug interactions. So the first one, how to identify cardiovascular risk factors. If you look at the InterHeart study, which was done on all continents that are populated in the world by Salim Yusuf a few years ago, he found multiple risk factors that led to coronary artery disease. But 90% of the population attributable acute MI burden is from 9 risk factors. The ones you know of, like smoking, hypertension, diabetes, and lipids, but also lifestyle issues like eating fruits and vegetables, exercise, how much alcohol you drink, are you obese, and do you have psychosocial stress? So 90% of these are attributable to these certain risk factors and are hence preventable. The way we assess cardiovascular risk is with the pooled cohort risk equation. Now the pooled cohort, it's called that because it's multiple different studies have been put in together and pooled together to allow these risk factors to be assessed. The risk factors for cardiovascular disease: gender, age, race, and the race they have in the pooled cohort is black and white. They don't really have Asians, Hispanics. Unfortunately, I'll show you in a moment way you can add those in. Your total cholesterol and your HDL cholesterol. And please note that LDL, although we all talk about it, is not one of the risk factors that we use to assess risk, mainly because we calculate it from the 2 lipid factors that are calculated or that are shown here. Systolic blood pressure and whether you're on blood pressure medicines, if you have diabetes, and if you're a smoker. So I tell patients to actually use the clincalc.com because they can go on their own computer at home, put in their risk factors, and find out what changing their risk would do to themselves. Then you hit calculate, and up will come this graph. It shows their 10-year risk, and this person's 10-year risk is 5.2%. If they were ideal, it would be a 4.3%. If you want to know what ideal is, you hover over the little arrow here, or the question mark. It'll tell you what ideal is for cholesterol, blood pressure, etc. This is very good because it also shows a risk for lifetime at the bottom. And you can see this person's lifetime risk is 36%, and with ideal risk factor modification, the risk lifetime, which is basically 30 years, would be 5%. Now the lifetime risk is only for patients under age 60, but it's very helpful for younger women who all have a very low risk burden, no matter what their risk factors are when they're young. The other thing that's always interesting is how many of the first cardiovascular events that occur, say if every person is going to have a heart attack this year in the United States, how many of them, if we assess them the day before, how many of them would be high risk? Would it be all of them, 95% of them, 92% of them? It'd be less than half. So less than half of the people that are having an infarct this year in the US will be termed high risk. And that's one reason the guidelines are pushing lifestyle so much, because a little bit of lifestyle change early in life can do a great benefit later, as I'll show you. Now, we had a couple of questions about drug-drug interactions and drug-disease interactions. Always think of secondary causes also of hyperlipidemia. So here's the secondary cause on the left: diet, drugs, diseases, and disorders that alter their metabolism. Some will elevate LDL, some will elevate triglycerides. Certainly trans fats everyone's aware of. Weight gain, anorexia, paradoxically, will raise, because you have liver abnormalities, will raise your LDL. Diuretics and amiodarone I've underlined because those are the classic ones we use in cardiovascular diseases. Amiodarone is one we use obviously quite frequently, and be aware of that. Biliary obstruction and nephrotic syndrome will be the classic diseases that will raise LDL tremendously. You'll see a patient with an LDL of 250 and check for nephrotic syndrome, a check for biliary obstruction. And then low thyroid will also be a case that can raise LDL. The triglycerides, the carbohydrates, always be aware that high carbohydrate intake will raise your triglycerides, such as alcohol. The medications that will do this, beta blockers, except carvedilol does not. The estrogens will tend to raise triglycerides, not so much LDL. Bile acid sequestrants will raise triglycerides, and steroids and protease inhibitors. Nephrotic syndrome is one of the diseases that will raise both triglycerides and LDL, and chronic renal disease. And then the poorly controlled diabetes, of course, you'll have high triglycerides, and then a low T4 will also raise both. The second issue, select appropriate non-invasive testing to risk stratify patients. So what additional factors, other than the pooled cohort, have been recommended that you use to look at patients when you're assessing them for their first cardiovascular event potential? The ones that are recommended are here in this box. It's expert opinion, but a level of evidence B. Family history, which we of course should always do. Check HSCRP is recommended, although it's not so helpful in individual patients. Calcium, a CT scan for coronary calcium is very helpful, as I'll show you in a moment. And then ankle brachial index, which you could do in the office quite easily. The ones that had neither a for or against recommendation or apolipoprotein B, the reason this is important is because every LDL particle has one ApoB receptor on it that is the atherosclerotic causing receptor. But it only helps in about 10% of patients, so we don't recommend it for everybody. Chronic kidney disease, a check for that does increase their risk. Albuminuria increases their risk because it's an index of inflammation. And then cardiorespiratory fitness increases their risk. But none of these are actually recommended for or against to check. The one that's recommended against checking is carotid intimal medial thickness. And the CIMT by itself doesn't really give you much helpful information, at least not over the next 10 years. What does help you with the CIMT is when they also look at carotid plaque. So if they have atherosclerotic plaque, that's helpful, but just the CIMT by itself is actually recommended against. So what levels do you look for with these 4 factors? Well, the family history is a male less than 55, a female less than 65. If it occurs older than that age, it doesn't warrant adjusting their risk. A CRP over 2, or 2 or over rather, is worth adjusting their risk. Under 2 is not. A calcium score of over 300 Agatston units or 75th percentile for age and gender is worth increasing their risk, not if it's below those numbers. And then finally, an ankle brachial index of less than 0.9 leads to increased risk and is worth adjusting the score. Now, no one ever gives you a direct number to adjust. I mean, you don't adjust it by 1.5 or 2.0, but just factor it in as you talk to the patients, and that's very important these days, that their risk is higher, and so the numbers I give you in a moment when we actually do the calculations on the pooled cohort, that's where you factor it in. Now, one of the questions that talked about coronary calcium, gave that as an option. The predictive value of a 0 coronary calcium is shown here in about 100,000 patients. And you can see about 45,000 had no coronary calcium. And their event rate was quite low at 5 years, on average of about 5.5 years. So in low or intermediate risk patients, a negative coronary calcium score predicts a less than 1,000, 1 in 1,000 event rate at a little over 5 years. Now the key here is low or intermediate risk. Don't use this the same way for very high risk patients. So if a familial hyperlipidemic patient comes in and has an LDL of 250, you can't use the CT scan because they're such high risk they may have an earlier infarct. So don't be confused about when to use it. Now the other thing about the calcium scan is that the MESA study, which is the multi-ethnic study of atherosclerosis, an NIH-funded study, has come out that includes now the coronary artery calcium risk, as you can see here. So you put in their calcium score, and it'll actually give you the risk based on that calcium score for them. The other advantages to the MESA, if you want to assess Chinese or Hispanics, this is the only risk score that really includes those two. It also includes the family history, and includes if they're on lipid-lowering medicines. So the MESA score adds, it's basically the pooled cohort, but they've added the MESA data to it. So it's helpful in these other categories, especially the ones where you're trying to add in calcium scores. And you can just search this on Google for MESA risk score, and it pops up. So what if your patient has a risk of less than 7.5%? You do the pooled cohort, as we'll talk about in a moment. Their risk is less than 7.5%, which is the cutoff where we say we should consider lipid-lowering therapy. What additional factors should be considered? So here's a 52-year-old woman with a risk of 6.8%, but her LDL is 170, her 62-year-old sister just had a heart attack, her CRP is high, she has elevated core cal, and her ankle brachial index is 0.8 with a lifetime risk of 28%. So any or all of the above of these, what do? Well, they all increase risk, so you discuss it with the patient. It's very important that the patient be involved, especially with statins, especially with a daily drug they have to take for years and years, because we know the statin non-adherence rate is around 50% after 3 months. That's right, the patients drop their statin by 50% after the first 3 months. So suggest to them, talk to them about lifestyle, which is extremely important, as I'll show you. Talk to them about alternative therapies, which are non-pharmacologic options, which will lower, especially diet, that will lower their cholesterol, and then talk to them about meds. And they have to decide, they have to make the decision. Next, how do you apply management strategies to prevention of CAD, including therapies to reduce their risk factors? Well, the lifestyle changes that reduce cardiovascular events, and this has been shown, as you can see here. The 4 major issues are smoking, body mass index, eating 5 fruits or vegetables a day, and then being physically active 150 minutes a week. So each of these, so 76% of patients don't smoke, 40% have a BMI less than 25, but only 1 in 4 or 1 in 5 of us eat fruits or vegetables adequately and are physically active. And it's no difference by age, sex, race, education, or income, because only 3% of us do all 4 of these. And if only 3% of us are doing them, you can tell that it really doesn't matter who you are. But if you do all 4 of these things, at least for a couple of decades, it'll lower your risk for a myocardial infarction, death, or stroke by almost 90%. Now, that's never been looked at in a prospective study until the ARC study came along and prospectively enrolled patients. It wasn't a randomized trial, but they did prospectively enroll them and found that if you did these 4 things, you'll lower your risk of infarct by about 40% within 4 years, which is really better than anything else we have. So we know that lifestyle is a risk factor. We know that adjusting lifestyle will reduce the risk. The ABCs, we've all had this, you've heard about the ABCDE for a long time. The things to remember for primary prevention, obviously assess the risk. There are multiple risk estimators available, as I showed you, the pooled cohort and the MESA. The Reynolds score includes HSCRP. In Europe, they use the SCORE, which is just a little bit, they're all a little bit different, which is somewhat disturbing to people. But the antiplatelet therapy, if you do a risk score and their score is over 10% for risk, then you should consider starting aspirin. The cholesterol, we'll talk about that in a moment. Diet and weight management, a heart-healthy diet, primarily the Mediterranean-style diet, and then regular physical activity, and we'll talk more about that in just a moment. And then calibrate the intensity of your treatment or your recommendations based on their absolute atherosclerotic cardiovascular risk. So this shows the duration in LDL lowering in a genetic lowering versus a statin lowering. By that I mean, here's the statin data from the 4S study, the heart protection studies, and others, that if you can lower LDL by 20, 30, 40%, you'll lower their coronary heart death by commensurate amounts. This is with a drug. Most of these studies were about 5 to 8 years. If you look at the genetic variants, so say you're born with a genetic variant, it could be a PCSK9 variant, it could be an LDL receptor variant or an apolipoprotein B variant, but you have a lower LDL because of it. But because you have a lifetime exposure or more years exposure to lower LDL, you have a much greater benefit in your risk reduction than you do if you just start a drug later in life. So this is where the idea of lifestyle, even early in life, is so important. So the greater duration of treatment equals the greater benefit. And that brings us to the PREDIMED study. And I was glad to see that many of you got that question right about the diets. That the PREDIMED was done in Spain. It was looked at acute MI, CV stroke, and death. And it showed that the patients on the control diet versus the ones on the Mediterranean diet with extra nuts or the Mediterranean diet with extra virgin olive oil, that the latter two groups did better. Now, there are three very interesting things to point out about this study. First is that the MI and stroke and death were reduced with the diet, and the greater adherence equaled greater reduction in events because they tracked and saw how much they actually ate or followed the diet. But the first thing is the study was stopped at 4.8 years by the Data and Safety Monitoring Board. And that's very unusual for a primary prevention study to stop early. They said it was unethical to continue the study because the people in the Mediterranean arms did so much better. The second thing is the event curves diverge very early, as you can see in the first 3 months. And this was not a lower your cholesterol diet. In fact, the cholesterol really didn't change much at all. It's basically an anti-inflammatory diet that changes the outcomes of a lot of diseases, as I'll show you, not just heart and stroke. And the third thing is, what was the control diet? The control diet was basically the American Heart low-fat diet. So the problem is the American Heart low-fat pushes so many people towards high carbs that gets us into trouble with other issues. So the Mediterranean, as I'll show you, is the one that's been felt to be the best and shown in multiple studies. I just want to point out the Mediterranean, the way we've defined it in most of the studies, there are 10 do's where you eat more, 4 things you do less of, and then have a little bit of alcohol if you want. I never recommend to patients to drink alcohol if they have troubles with it or have religious reasons against it. But olive oil is the first of 3 of the 10 things you should do. Fruits and vegetables are very important. Having a half of a tennis ball of nuts a week. So you tell men have a handful of nuts a day, or maybe 12 nuts a day, 12 almonds. And you have to point out to them that's not 12 handfuls of almonds. Legumes is anything that breaks in half, any bean, fish, and then a light meat, poultry is also in there. The things to avoid, of course, more than a deck of cards of red meat, anything out of a box, any high amounts of dairy, and then colas, because they're felt to be inflammatory to the endothelium. And then you do get a little bit of wine. So I give this to patients and tell them to try to adapt to this over time. It takes a year or two. But what are the benefits of Mediterranean diet? Not just death of cardiovascular disease and stroke, but also lowers death of cancer, lowers diabetes, lowers Alzheimer's, arthritis. It's an anti-inflammatory diet, and Parkinson's disease. And then its erectile dysfunction improves, and it's the only diet shown to reduce female sexual dysfunction. So it's primarily an anti-inflammatory diet that it seems to be its most effective way. And that's the monounsaturated fats from the olive oil, the avocado oil, the nuts, things like that. So how many patients come and say, Doc, I want to take a statin so I can eat whatever I want? And that's very common, unfortunately. How beneficial is healthy eating when you're taking a statin? If you look at the Modified Alternative Healthy Eating Index, which is basically an index of the Mediterranean diet, and look at the outcomes of death, MI, stroke, or heart failure, you can see that here were studies, the On-Target and Transcend trials, which were both statin trials, placebo versus statin. And you can see that if the patient was on a statin and they were in the 2 unhealthiest diet groups, quintile 1 or quintile 2, that their line of identity for reduction of events crossed 1. So you actually, 40% of the patients get no benefit if they're not eating a healthy diet. And that's very important to remember and to bring across to patients and to yourselves personally. If you're not eating healthy, the benefits of a statin are significantly reduced. Now, the one question always comes up is what's better for you? Is it to be cardiovascularly fit, or is it to have physical activity? Things like moving around, having a standing desk. All those things are great, but what really helps you the most? If you look at the fitness reduction in risk versus the physical activity, and fitness is shown here in blue, you can see that the fitness reduction is about a third, but the physical activity reduction in events is about a third, but the cardiovascular fitness is defined by a stress test or something like that, will reduce your cardiovascular events by 2/3. So it's great, tell patients it's great to be moving, it's great to walk, it's great to use the stairs, have a standing desk, whatever, chew gum, anything. But you want to be fit. That will give you your greatest reduction in your cardiovascular morbidity and mortality. So finally, how do you initiate appropriate lipid-lowering therapies and recognize side effects? There are 4 groups to be considered for lipid-lowering therapies per the guidelines in patients over 21. First, screen for cardiovascular risk factors and measure their LDL. If they have any known atherosclerotic cardiovascular disease, then a high-dose statin, and we'll talk about the doses in a moment, is recommended. The other group that's recommended are LDLs over 190, and this is the idea behind this number was to try to find patients that have familial hypercholesterolemia. We'll talk about in just a moment. But these 2 groups should be initially considered for treatment and suggested. The third group are the diabetics, age 40 to 75, that have LDLs from 70 up to 190. You assess their 10-year risk, and if their 10-year risk is less than 7.5% by the pooled cohort, then a moderate dose statin. If it's over 7.5, consider a high dose statin. And the other group would be patients that don't have diabetes, assess their 10-year risk, and only consider treatment if their risk is over 7.5% or greater at 10 years. Now, the 2 groups that this doesn't really apply to per the guidelines were patients with heart failure, New York Heart Class 2 to 4, or they have renal failure on dialysis. It's not because the statins don't help them much, it's because they have so many comorbidities and so many other events that the benefit of statins is kind of washed out by their other events. So it's really not recommended for or against. It just said you don't use it for those types of patients. However, if you have a patient that needs the therapy because of that, they have coronary disease, you can certainly give it. This is similar to the elderly. If you have an 85-year-old patient, they have so many other events that occur that you really can't help them much with a statin. But if they're having angioplasties and bypass and such, then certainly consider treating them to lower their LDL cholesterol. Now, the dose, the high, moderate, and low intensity statin dose, you can see that the high is considered it lowers their LDL by 50%, and then the moderate is 30 to 50, and then low would be less than 30%. And here are the different drugs names here. The high dose would be atorvastatin, 40 to 80, or rosuvastatin, 20. The color coding here, as shown on the bottom, is that if it's in yellow, it's been shown in a randomized trial to lower major cardiovascular events, or it was in the the treatment trialist collaborative that was published in Lancet a few years ago. If it's in parentheses, it hasn't been shown. If it's white, it hasn't been shown, but it's assumed because that's a higher dose, and you assume it would still show benefit. And the asterisk is what you give if they won't tolerate a higher dose. So atorva and rosuva are the 2 high dose. Atorva and rosuva at lower doses would be the intermediate dose, and then simvastatin or pravastatin would be the dose for the low risk patients. And what's the monitoring recommendations? And this always gets confusing. You know, how often to test the lipids? You should do them twice pre-treatment initiation. That's the recommendations. Most of us really don't do that, especially if your patients travel from far away. After treatment, about 8 weeks plus or minus a month, they'll hit steady state at 4 to 6 weeks, so you can do it a month later if you want. And then after you start or you change the dose, and then annually after that. How often to test liver function? The recommendations in the guidelines are to test it as often as you test the lipids. However, the FDA has come out and said just check the liver function the first time you check, you start a dose or raise a dose or start a new drug. After that, they're very unlikely to have a new liver reaction after a month. When to check a CK, pre and then post only if myalgias. I don't check CK pre except in African American males. That's not in the guidelines, but about 8% of African American males have a high CK to start with, even before statins, although that's not guideline. That hasn't made the guidelines yet. And then when to stop a statin. If their CK is less than 5 times upper limits of normal, you can continue the treatment. If they have symptoms, check their CK regularly. They don't define what regularly is. If it's over 5 times upper limits of normal, then you should probably stop it and check their kidney function, and then check it every couple of weeks until it clearly starts to come down. Liver function, remember the liver is more important to you than your muscles, so liver elevation should be 3 times upper limits of normal, and you can still continue it unless it goes over that. And then the same thing, just follow them until you know it's going to come down. And the FDA has come out with a statement about simvastatin, that certain drugs are completely contraindicated with simvastatin. As you can see, a lot of the antibiotics, the erythromycin, antifungals, the protease inhibitors, and then drugs we use a lot like gemfibrozol, don't go over 20 milligrams of simvastatin with amio, amlodipine, or ranolazine, and 10 milligrams of Simva with verapamil or diltiazem. So remember the amiodarone and the calcium blockers are the main ones you have to be careful with. Now, in statin-treated patients, try to use the maximum tolerated intensity of statin. If they can't tolerate it, let them wash out and go back to the dose they can tolerate. Consider a non-statin addition if they have less than anticipated response, only if the benefits outweigh the risks. Meaning if they're high-risk patients, if they have known disease, if they're high LDL or they're diabetic, then consider it. And what drug to use? Primarily, it's ezetimibe. That's been shown in the PROVE-IT study, or IMPROVE-IT, to help and add to statin therapy. It's also generic now. Be careful with niacin, because niacin, when given with a statin, will increase the risk for toxicity. So we try to get patients off of that. Studies have actually shown it does not lower events. It makes your numbers look a little better, but it does not lower cardiovascular events. And then bile acid sequestrants are the one to consider, but they're of minimal benefit. So basically, it's statins with or without ezetimibe. And PCSK9 inhibitors are the future. The issue with PCSK9s is they're quite expensive, if you may have heard. So you have to use it primarily in familial hypercholesterolemia. When to think of familial hypercholesterolemia: when their LDLs are over 190 and they have a family history of early coronary disease, either in themselves or in first or second degree or third degree relatives, because the FH will penetrate out to third relations. This is the group you get concerned about when those two overlap. The CDC has said, about 3 or 4 years ago, came out with an edict. There are 3 diseases we need to find early and treat early because it can reduce the lethal effects of an autosomal dominant disease, and one of them was familial hypercholesterolemia. So the patients we're primarily using the PCSK9 inhibitors on are these 2 that have disease and they can't get to goal with their standard therapy. That's about almost 1 million or 2 million people in the US. So maybe 1 in 150, 1 in 200 million people. The more we look, the more we're finding patients that have high cholesterols. And once you find one, then you find all the family members with the cascade testing. The group to be concerned about that has reached guideline level are statins in Asians. There's an increased incidence of muscle symptoms in Asians. It's primarily Southeast Asians, Indian subcontinent and Southeast Asia. And they came from data looking at like the HPS Thrive study, where they used the same protocol in multiple countries. And they found that in China, the placebo rate and the statin rate of myopathy, statins were much higher, maybe 5 times higher, than it was in the Euro-Caucasians. So myopathy was higher, and in equivalent doses, the Asians achieve greater LDL reduction than Westerners or than Euro-Caucasians. So the guidelines have pointed out, consider starting with a lower dose, maybe a quarter dose in an Asian or Southeast Asian when you're starting a statin, rather than starting the full dose. Always talk to the patients about their Ps, their priorities, their preferences, and then you show them the proof that actually what helps a patient. And the internet, as you know, is full of all sorts of crazy things out there, and they're going to bring it into you. but just show them, try to show them and lead them to some good data, and then ask them what their priorities and preferences are. Why is that? Because the patients look at the cost of a drug, and they look at the risk of the drug as being right now, but the benefit is 5 to 10 years later. So it's very difficult for patients to assess their risk and their benefit, because the troubles are now, the risk is now, but the benefit's much later. So it does take a conversation, and it has to be an informed decision on their part. So discuss statin side effects with the patients. That's one thing the guidelines has pointed out very clearly. About 90% of the side effects are myalgias. Stop the statin for a month. If that occurs, then reevaluate symptoms. If their symptoms are better, you can restart, or if they're no better, start the same drug back. If they are better, then you can try a different statin. They're all generic now. And less than daily dose is an option. It hasn't ever been shown to improve outcomes because no one's ever studied it, but it is an option, and it's better than no statin at all. Diabetes is a risk. It usually occurs in those who are already at risk for diabetes. They have high fasting blood sugar, a high A1C, they have metabolic syndrome. And remember, if you start a statin in them and they have a high risk, they have a 5 to 10 times more cardiovascular events will be reduced than diabetes occurs. And in most studies, the diabetes will occur about 2 or 3 months earlier on the statin than if they're not on the statin. And then finally, memory loss, that's pretty rare. It's been shown in multiple studies not to be an issue, but patients are all concerned about it, and so you have to discuss it with them. So the lipid-lowering treatments, to summarize, determine their risk, encourage a healthy lifestyle, discuss the benefits, the risks, and the cost of the lipid-lowering therapy. If a patient favors lipid-lowering therapy meds, then use the drugs supported by evidence, and then regularly reassess. For primary prevention, it's low to moderate intensity statin, and to intensify treatment as per the patient's desire for greater risk reduction. So thank you for your attention, and welcome back, Nish.
I'm going to have a seat. You can see why we always call Dr. Kopetsky, because it's just so practical, so well outlined, so clear around all this amass of literature that we get on primary prevention. So let's go back to this first question here. This 48-year-old woman, paroxysmal atrial fibrillation, her LDLs popped super high to 192. The most likely cause of the LDL is the amiodarone, estrogen, diltiazem, warfarin, or hydrochlorothiazide. So hopefully you will have a lift in your answer. Let's see what you got. Okay, better.
All right.
Any comments, Steve, about the estrogens or any of the others? And
Yeah, the estrogens, I mean, it does raise triglycerides, and be careful about it from that regard. And hydrochlorothiazide can also be an issue, but this patient was on it long term.
yeah, but the amiodarone is the big thing.
Amiodarone.
Okay, and that table that he has is an excellent table about which of the drugs affect the cholesterol and triglycerides. One of the questions from the audience is, you had talked about kind of the calculated versus the measured LDL. Can you tell us the difference between that and which one we should use?
Yeah. The calculated LDL, it's really, most of the countries in the world use apolipoprotein B because it doesn't have to be fasting. We use the LDL calculated. There's a move now to going towards non-fasting levels, and with the calculation you have to be fasting because triglycerides is one part of the equation. And if you're not fasting, your triglycerides will go markedly up. However, the studies have really shown that you don't need to be fasting, that using a non-HDL cholesterol is probably just as good as using an LDL. Just add 30 points to the non-HDL. Mm-hmm. And so I think we're going away from fastings, but that'll be over a few years.
All right, sounds good. Let's keep on going with this woman here. You're seeing her in late February. She brings a CT scan for coronary calcium with a score of 1,263. No risk factors, ECG normal, no symptoms, no MI, physically active. Which of the following are true? No easy way to add CT results into her risk score. Statins have not been shown to be helpful in this group. She should have a stress test. If her score was 0, her MI risk would be less than 1 in 1,000. physical activity has no effect on statin benefits. So there's a number of points in this question that Steve outlined throughout the talk. Let's see what you answer. Okay, 91%. They can clap if they get 95, but they didn't achieve it.
Oh, really? Oh, shoot. Sorry.
Okay, but anyway, do you want to talk about the calcium score a little bit more detail? In other words, there were some questions on who do you send for a calcium score in your practice?
Yeah, that's a very good question, because if in America, if you're a man, by the time you get to age 60, 90% of us have positive calcium scores. So it's not going to help you much in a man that's age 60. Also, below age 40 for a woman, or really even age 50 for a woman, they're not going to have calcium. So it's mainly, I order it in men that are 40 to 60 and women that are 50 to 70. And that's who it may really help you in.
Okay. And then on hers, since she now has a CT score, how would you score her risk? What would you use?
Yeah. And then you can go into the MESA risk score, which actually calculates in the Agatston score for coronary calcium. Put that in, and it will tell you how much incremental risk increase there is. There's been one study that's been a randomized trial that if you have an LDL or have a coronary calcium in that 300 range or above, then you benefit by statins, even if you're asymptomatic at the beginning.
Okay, so the pooled cohort is the one that's kind of recommended in the guidelines, but if you have the additional information, you go to the MESA score.
Right.
And the way that they asked how you find it, I think you said it, just Google it, is that right?
Yeah, Google MESA risk score. If you're in Mayo World, Mayo Land, we actually have it on our dock up front. Yeah. Just bring up patient care cardiology, and there's the MESA score.
Yeah, and I think in the future, all your electronic health records will be able to automatically calculate the scores for you. Yeah. You know, one thing about the risk factors is you had talked about Yusuf's paper with the psychosocial component being a risk factor. What's a psychosocial component? How did they define that?
Yeah, it's defined different ways. One is job stress. If you have high demands and low control of your job, that's by definition job stress. Doesn't sound like anything in medicine. And those patients have actually been shown, if you can lower their stress and the simple technique I recommend to almost everybody is practice optimism, which means, is Sue talking to you about stress here? It is when you go to bed at night or when you wake up in the morning, think of 3 things you're thankful for. And it could be because you came to Nishimura and Alman's great course or whatever it is, but the 3 things you're thankful for, and it's been shown that if you do that, you actually increase your optimism and you decrease your heart attack rate at 5 years.
Really?
3 things, yeah.
Wow. Okay, 3 things. Write down 3 things that you're thankful for. Define CV fitness. You talked about the difference between exercise and CV fitness.
Yeah. The cardiovascular fitness would be, it could either be, it's usually a stress test. Most studies have used a stress test with a Bruce protocol because it's a standardized test. We know how far people should go. And we usually call fitness 100% of what's predicted. That can really help you tremendously. A 6-minute walk is not quite as good in the young patients, but it's good in the older patients because a 6-minute walk is harder for them to do, over age 65.
So it's percent FAC on a treadmill, basically.
Essentially, yeah.
Okay. And then there was another question on, you like to show them their score with and without risk factors, and one of the big things is the tobacco. What about the e-cigarettes?
Yeah. E-cigarettes, if there are a lot of nicotine in the e-cigarettes, that can cause certainly coronary vasospasm, but the data is really not real clear on how they affect coronary disease long term. We just haven't had them around that long.
So what do you tell them?
I tell them to get off it, stop it.
Everything.
Well, stop the nicotine if they want to, inspire on something, but just get the nicotine and all these chemicals out of the e-cigarette.
Okay. All right, let's keep on going to the diet now. The nutritional pattern that's been shown to lower CV morbidity and mortality is the DASH, the Mediterranean, the DASH in the AHA low fat, the Mediterranean paleo, the DASH in the Mediterranean. Okay, Steve, you got a few.
So Mediterranean, yeah, that's very interesting. That I didn't mention the DASH, and the DASH has been shown. You said you had a talk yesterday.
Yeah,
on
Amy
DASH.
gave a talk on hypertension.
Yeah, the DASH has been shown to reduce cardiovascular morbidity and mortality. The Mediterranean has been shown to reduce cardiovascular morbidity and mortality. Amazingly, the American Heart Low Fat is one that's not been shown to reduce it. But so it really is important. In DASH and Mediterranean are basically the MIND diet that you may have heard of lately, which is basically the M for Mediterranean and the D for DASH.
Oh, combined.
And basically they're essentially the same thing, except the Mediterranean has more olive oil, more monounsaturated fats, and nuts.
Okay. And then there must be some vegans in the audience. They asked about vegan diet.
Yeah. A vegan diet can be very helpful, but some vegan may not be that good. You know, if you have like a lot of coconut oil, which will raise your LDL cholesterol significantly, it actually raises it more than lard or butter would raise it. And so you have to be careful with what you're eating vegan. But in general, it's a great diet.
Okay. And has a vegan diet been shown in itself to reduce cardiovascular risk?
Well, defining as a vegan, no, has really not been shown. There's talks about Esselstyn's diet, which is very low oil. There's obviously, he's never shown anything, any outcomes data. There's also Dean Ornish's diet, the Lifestyle Heart Trial, which was it was a very high fat type of diet, low carb. He's shown reduction in cardio in coronary artery disease progression, but never actually outcomes data. The outcomes has really just been these two studies, the DASH and the Mediterranean.
DASH and Mediterranean. Okay, let's go to the last one. A 63-year-old man with the hypertension, father had an MI at age 64, pooled cohort risk is 14%, LDL is 126 on amlodipine, hydrochlorothiazide, metformin. What medication is contraindicated in this patient? Rosuvastatin, atorvastatin, simvastatin, fluvastatin, or pitavastatin? They can clap.
All right.
Okay, so the simvastatin definitely is the medication that's contraindicated here. But, so we don't need to talk about that anymore, but there were some more questions on kind of the statins. So you said recheck the LDL level within 1 to 2 months. What do you do at that time? Do you change your dose? Have we gotten away from target levels? What actually should happen?
Yeah, the guidelines still have a target is 50% reduction.
Okay.
That may change when the next guidelines come out at the end of 2018, but for now it's still a 50% reduction from the cardiology guidelines. If you look at the endocrinology guidelines, the European guidelines, every other guideline says 50% reduction or LDL of 70. So if all the diabetologists go to 70. In fact, most cardiologists do that too, but the guidelines don't say that. They say 50% reduction.
Okay, and what do you do?
I go 70.
Okay, so if your maximum dose statin does not get them to 70, what are you adding right now in your practice?
Well, then re-review their lifestyle, re-review what they're eating. As I said, studies have shown that if you go on a statin, you actually eat worse, you eat more calories, and you eat more saturated fat.
Yeah.
So talk to them again about that. Talk to them about changing, making sure they're taking their pills. There's a 50% non-adherence rate over 3 months to statins for primary prevention. And the third thing is give them some options. You know, a different statin, a higher dose statin, adding a generic ezetimibe. Any of those things are reasonable options.
Okay, and even though it won't be on your boards because it's controversial, at what point in time do you go to the PCSK9s with your own patients right now?
Yeah, it's the triad of FH.
Okay.
It doesn't have to be genetically proven since probably half of the cases you don't find a gene. They have coronary disease or cardiovascular disease of some sort. Could be a CT scan for calcium, could be a Brui, something like that. And third, they just can't get to goal with this therapy that you give them. Usually high-dose generic rosuvastatin and then add ezetimibe.
Okay.
And most drug companies or most pharmacy benefit managers will want you to have the patient on ezetimibe and a statin for 3 months before they'll approve the PCSK9.
Okay, so your highest dose statin, your ezetimibe, if after 3 months in a high-risk patient, if you can't get to, you use 70,
Yeah.
you would then consider adding that.
Yeah, if they're high risk, have disease.
Okay. And high risk is defined as?
Well, if the LDL over 190 is the guideline, high risk, and that's at the beginning of all
Yep.
this, not at the end of it.
Okay. And then there was a question on pregnancy. You know, if you have a woman who's got hyperlipidemia, you have them on a statin, she's pregnant, what do you do with the statin?
Yeah.
And,
Then just hold the statin while they're trying to get pregnant.
okay.
Don't stop it once they get pregnant. Hold
Okay.
it.
Hold it while they're trying to
Yeah.
get pregnant.
And the
then.
PCSK9s, we have no data on pregnancy.
And then finally, we didn't ask you to cover this, but there were a couple questions that came out with primary prevention. Can you talk about aspirin and antiplatelet therapies?
Yes, the guidelines have said that if your risk is over 10%, you should consider starting aspirin.
Okay.
The interesting thing about risk for heart attack as you go through life is your risk for heart attack goes up. As you go through life, your risk for bleeding with aspirin goes up, and I asked what goes up faster, it's the risk for bleeding. So when you're in your 40s, you need to have about a 12% risk or so of an MI to really benefit from aspirin. As you get older, it needs to be, about a 6% risk. But as you get older, you have to, like over 70, you have to have about a 12% risk to really benefit and not have bleeding.
So in your practice, this calculation of risk is pretty important for pretty much everything, huh?
It's really important, and it's very important to tell the patients how to do it. Say, here, go on your computer and figure out your risk and changing things, how much it will benefit you. I mean, they're the boss. They run the show.